One and all of you friends and moderators on the dais. My due in this next few minutes is to talk about a dialysis of nearly 5 clock hours and what is the answer. How else could you think retrofixated IOL? By the end of my talk, I would wish that each of you go out to the hall thinking that retrofixated IOL is the answer. Because let's understand, dear friends, that in a debate, the truth has to be our aim and not just victory or not just an unjust interest. And we have that key in our hand, the retrofixated IOLs for in the bag where the capsular support is lost. Let's be reasonable at this point of time. If you have a room full of students, why would you not want to make a lesson easy enough for them, but why would you want to make it tough and difficult for them? And having understood that definitely this is easy, the other huge advantage which you face here is there are no special and complicated instruments here. As I'm going to show you the procedure, it either needs a scleral tunnel or a well-constructed corneal incision. Remove the cataract if it is being done in a primary procedure, and then of course enlarge, do a good anterior vitrectomy, enlarge the incision and just slip in this retrofixated IOL, go through the side ports and just enclavate it behind the iris, and there remove the viscoelastic, and then the work's done. So now we understand it's so easy, as you're going to be seeing all those other surgical procedures which you're going to show. When it is so easy a learning curve, then what strikes our mind is that you could do it as a primary fixation and you're just able to save a need of an additional surgery at a later date. So then the next answer is you're able to do something here with minimum time and maximum productivity, and then get the patient back to routine work as early as possible. But having stated such profound statements, we need to assess the centration, the results, the long-term effects. And this was one 5-year study which was done, which showed that the visual outcome was excellent at first week and continued to be stable over 5 years at different time points. This was another study which compared number of eyes which had undergone a retrofixated IOL as against an SF IOL, and at all time points again, all of these patients had 20/40 or better vision in the retrofixated IOL group as against the SF IOL group. But then there is an issue. Many of these surgeries are done in eyes which already have some comorbidities, or these are surgeries which are done in eyes which have had a complication. So then there are some more parameters which we need to visualize. Like these are again, we need to look at the safety of the procedure, and there were again any number of studies which came up when I did a literature search that it continues to be safe, well away from the endothelium, well away from the angle structures, and most importantly, although this is fixated on the iris, a good pupillary dilatation is quite possible and absolutely safe. The other question which comes up is, would there be an intraocular pressure hike when you're dealing with an iris tissue? And then therein again came a 5-year study which convinced us that at all time points, a well-done surgery, the intraocular pressure would be controlled unless there have been serious complications in the primary surgery. The endothelial cell count in again another study showed that it continued to remain stable over a 5-year period. Now I'm going to show you 2 surgeries at the same time. The first eye, it was erroneously just a CTR was placed, although the area of dialysis was large. So you realize that the lens was subluxating, so you need to remove the IOL, search for the CTR, remove the CTR, and just push in a retrofixated IOL. This was a young pediatric eye, and you could see the utter ease. The only thing you needed to create a scleral tunnel because it's a young eye, it's because of the lack of scleral rigidity, and then go in, complete your surgery. Just do an anterior vitrectomy in the former, but in the second case, you do not even invade the vitreous or the posterior segment and just slip in the iris clip lens, and it's barely edited surgery. It just tells you how fast the surgery gets done. This is again another surgery which was done in an eye with a phacolytic glaucoma, and you would be sure, of course, the decompression, giving max Dimox, everything was done in these eyes, but all that was needed here was just a good scleral tunnel, 2 side ports at 3 o'clock, 9 o'clock position. Just get the hard cataract as it is, just scoop it out, do a good vitrectomy, and just slip in an do an anterior vitrectomy, and there the retrofixated IOL is in its place. So why would I look at all those options they are going to talk of, where you could have a lens dislocation, you could have a suprachoroidal hemorrhage, you could have a vitreous hemorrhage, because you have invaded the posterior segment. Even ultrasound biomicroscopy tells you that the sulcus fixation is not exactly where it should be in these eyes. I agree there are some concerns of some people saying an ovalization of pupil, but then I would say astigmatism may be the only issue of concern because of the larger incision which is needed. Pupillary dilatation is good. This was another 5-year study which showed that the amount of CME occurrence was just 0.9%. Yes, there is no established consensus or the best treatment for eyes with inadequate support of capsule. There's no randomized trials. But then, it's easy and the best, so why do we not look at a retrofixated IOL? And there, I have listed you all those points which tell you why all of us should think of going in for a retrofixated IOL. And don't you think we would take excellent as a first choice? Thank you very much.
Thank you, Dr. Chitra.